Let me give you a little bit of background information about Community Health Systems. The company was founded in 1985, actually was started in Houston, and like most companies that start up, it was originally backed with private equity and venture capital money, and our largest private equity backer was a group named Forstmann Little. And in 1996, Forstmann Little hired a gentleman by the name of Wayne Smith to become the CEO and president of the company. And Wayne Smith is still our CEO and president today. To give you some perspective as to how we've grown, when Wayne came on board as the CEO of the company in 1996, we were 35 hospitals and approximately $600 million in net revenue. Today we're 135 hospitals and $13 billion in net revenue. Also, immediately after Wayne was hired in 1997, we went public. The company trades on the New York Stock Exchange. It trades under the symbol CYH. Because we're publicly traded, there's all kinds of information you can learn about us. We have to follow all the Securities and Exchange Commission rules with regards to disclosure of information. So we provide annual reports and we provide quarterly reports, and anytime anything significant in the company happens, a disclosure is made. If you go to our website, which is www.chs.net, you can find all of our, it's got a lot of very useful information. There's a map there that shows where all our hospitals are located. It has bios on all of our management team. All of our SEC filings can be found through our website. So there's some of our investor presentations are there as well. So you can learn a lot about the company by visiting the website. We have a fairly sizable business in Texas. We have 17 hospitals in the state that operate on 18 campuses. I guess to give you, let me back up to a second, and talk about the company. I want to give you a sense of, again, a perspective on our size. We have about, across the company, we have about 16,000 medical staff members. We have about 90,000 employees. And we treat about 700,000 inpatient admissions every year in our hospitals. So our company accounts for roughly 2% of the admissions, inpatient admissions in this country. We also, see about 1.2 million ER visits, and again, our net revenue is $13 billion. And Texas represents one of our largest states. It is about 13% of our company. We have about 1,600 active medical staff in the state. We have about 10,000 employees. We see over 400,000 hospital inpatient admissions, and we do about $1.7 billion in net revenue in the state. You've probably driven by our hospitals and didn't even know that they were our hospitals, and the reason is because we don't brand our hospitals like a lot of organizations do. So, there's an organization called HCA. It's also a publicly traded corporation. They have branded all of their hospitals with the HCA symbol. So when you go down to Conroe, Texas, and visit that hospital there, it's an HCA hospital. We, on the other hand, have chosen to use local names for all of our hospitals. So I'll give you an example of some of our hospitals. We own Woodland Heights over in Lufkin. We own the Med over in College Station. We own Tomball Regional in Tomball. We own the DTAR system in Victoria, Texas. This is just an example, but we have chosen an approach where we try to, typically what we do when we take over a hospital, either acquire it or lease it, is we use whatever the legacy name of the hospital is. We incorporate that. So anyway, that's a little bit about our Texas operations. I've got 9 or so topics that I would like to discuss with you this evening. First of all, let me kind of start with our overall corporate strategy. and then I'm going to get down into what some of our individual hospital strategies are, but I kind of want to start at a corporate level first. And basically, I'll start with the fact that what we're trying to do is create better places for our physicians to see patients and for our employees to work and for our patients to receive care. That is the mission of our organization. And our goal is to be the provider of choice, the healthcare provider of choice in a local community. One of the things that we have embarked on in the last several years in order to be that provider of choice is we have started to create integrated delivery networks. Okay, so what that means is we're working with our hospitals, with physician groups, with ASCs, with imaging centers, with home health, hospice, and we're creating a network where members of the network help each other. They help each other for things like group purchasing, contracting with managed care organizations, sharing back office support and resources and that sort of thing. So, we have been working on this in a number of markets across the country, and it's really kind of the future of where healthcare delivery is going is you want to be part of an integrated delivery network. We've also heard a lot about healthcare reform over the last few years since President Obama has taken office. It's signed into law. Parts of it have been enacted. Some parts were still waiting to be enacted. But we have been positioning ourselves for healthcare reform now for several years. So for example, we know that in the future, the way a hospital is reimbursed is going to be different from today. We know in the future, hospitals will be reimbursed based on value and also quality. So we've been focusing on things like clinical core measures, readmission rates, reducing infections, reducing injuries, and improving patient satisfaction in our hospital, because those types of things are going to be incorporated in your reimbursement in the future at a hospital. So we feel like we are positioning ourselves well for healthcare reform. We are also testing frameworks and relationships as they relate to accountable care organizations. Some of you have heard this term. In my mind, it takes us back a little bit to the managed care strategies of the President Bill Clinton days, but it is taking on risk, for a population, and so and this is likely to happen. So we are, forming relationships with organizations so that we're well prepared when accountable care, comes to fruition, and it's going to come to fruition in some markets faster than it is in other markets. So we have a geographic footprint that goes from Pennsylvania all the way down through the southeast, through the southwest, and even all the way up to Alaska. What we're seeing is that, that accountable care and healthcare reform is really taking hold very quickly in the Northeast. And so we're having to ramp up very quickly in the Northeast for these type of models. But the benefit is what we learn up there, we then take and infuse that into the rest of our hospitals across the country. Let me talk a little bit about charity care and community benefit. And just so you know, I've got 10 things that I want to talk about this evening. So I'm on point number 3, charity care and community benefit. A lot of times I represent what they call an investor-owned company. So, and sometimes we're referred to as for-profit. And there are many misconceptions about for-profits not providing, charity care or community benefit services. And I can't speak for all the companies in the for-profit sector, but I can speak for my company. And I can tell you that we do our fair share of providing charity care and community benefit services. In fact, of our $13 billion in net revenue, approximately $3 billion of that is uncompensated care. And by that, I mean bad debts, charity care, and the discounts that we give to patients that are uninsured or underinsured. So approximately 20% of our net revenue ends up being uncompensated care. Also, and when we go into a community, what we typically do is adopt whatever the financial aspects are of that hospital's specific community charity care policy. So it's usually based on a percentage of the federal poverty levels, and if that's the accepted norm in a community, that is typically what we adopt.